Hey class, welcome back to Intro Psych. We are in the penultimate chapter of the King text, which means we only have this chapter and one left to go. Last chapter we covered chapter 12, looking at various disorders. Now we're going to look at chapter 13, how those are treated. We will be looking at various approaches to treating psychological disorders, specifically looking at the difference between psychotherapy and biological therapy. And then we'll turn and look at some more approaches based around sociocultural psychology and issues that might arise during treatment. So when we talk about therapies, whether we're talking about biomedical or psychotherapy, the ultimate goal is the ultimate goal is to relieve suffering, to put an end to the suffering that an individual is facing, based on having a psychological disorder. So, for example, somebody who is diagnosed with an anxiety disorder, maybe just generalized anxiety, the idea is providing some form of treatment that will relieve them of those anxiety symptoms. So, there's a couple of approaches. There's a psychological approach, which is, the entire field of clinical psychology is built around administering psychotherapy, otherwise known as talking therapy. This can be done in an individual or group setting. It is a non-medical intervention, meaning we're not prescribing medications, we're not performing some kind of procedure. Those who might administer this kind of therapy could be a clinical or a counselor, clinical psychologist, or someone with a counseling background. Social workers, like licensed clinical social workers, can administer psychotherapy depending on your training. Conversely, there is the biological approach, which is really addressing mental illness the same way we would a physical illness. We can use medications, we can use biomedical treatment. And in this case, we're talking about medical professionals. A psychiatrist is typically who we're talking about, who has a medical degree and can do that. Now, there's also, your general practitioner, for example, can prescribe medications. You can go to your general practitioner. Let's say if your insurance wouldn't allow you to go to a psychiatrist, you probably could also go see your just everyday doctor, and they might be able to prescribe you something like an antidepressant, an anti-anxiety medication. Now, these folks are not typically trained specifically in psychopharmacology, but if cost or insurance is a thing, it's not like that's your only hope. As seeing a psychiatrist, there are other options. A sociocultural approach is understanding that individuals who seek treatment, who are suffering from mental illness, are part of a system. That system can be the society we live in, the family, your friend, all of these interconnected aspects of a system. In some cases, then you might have a team working on, or a collection of individuals in mental health treatment. Maybe you have a psychotherapist, you have a social worker, paraprofessionals involved as well, who might be administering some form of treatment. So when we think about, how effective is psychotherapy? Well, for the most part, all therapies are the ones that are obviously evidence-based are winners in the sense that they are better than no treatment at all. If we look at research that shows individuals who improved based on whether or not, they're receiving psychotherapy, maybe, or compared to a placebo, maybe taking medication that's not actually really medication compared to no treatment, there's a pretty big difference in the amount of individuals who, self-report or demonstrate improvement. Ideally, we want to use therapies that are evidence-based practices, meaning we want to use therapy, not all therapy is equal. All therapies can be considered winners, but not all of them are equal. Like, you would treat phobias with a different kind of therapeutic set of assumptions than you would, say, major depression or schizophrenia. So you want to make sure that the treatment is aligned with what the evidence suggests. Really, any kind of therapy we're talking about, if it's going to be successful, ideally it needs to be the alliance between the therapist and the one receiving therapy needs to be aligned, meaning they need to be on the same page. You want a therapist who has expertise in the specific area of concern, and their style, maybe how they approach psychotherapy, matches with their client's personality. And this is something that both sides have to be very active in. It can't just be a therapist, taking notes and telling you, go do this, go do that, and come back a week from now and tell me how it went. You have to be very active. A lot of times, therapy goes beyond the walls of the therapist's, office. At times, maybe you're given homework that you're, asked to do in between sessions. And the more active an individual is in their own therapy, the more likely they are to recover. So therapies come in all shapes and sizes. One of our earliest experiences of therapy comes from Freud. Freud is pretty much the father of modern Western psychotherapy, with psychodynamic therapy. So a lot of this stuff will be familiar to you, but in a different context. We're talking about Freud. So anytime we talk about Freud, early childhood experiences matter a lot. Conflict at the unconscious level, those forces, id, ego, superego, kind of butting heads, is the source of our tension, our anxieties, things like that. And the therapist's job is to interpret events, the things that the individual is saying, their dreams, their free associations, and use that as a way to kind of tap into that unconscious portion of the mind. So the entire goal of this is for clients to have a better understanding of those unconscious conflicts that probably develop during childhood and they're not aware of. So Freudian psychoanalysis is built around principles of free association, where clients just simply say whatever comes to mind. The therapist really isn't going to say a whole lot. They're probably back there taking notes. They might ask a question and just let that person go, say whatever they, there's also, it's built around this idea of catharsis. It's a good thing to let vent and get some of those frustrations and tensions and worries out. And everything is up for interpretation. Everything is up for analysis in this kind of therapeutic program, meaning your dreams, the way you treat the therapist. This can sometimes be referred to as transference. If you are engaging with a therapist one way, this could be an example of you transferring feelings from one relationship to the therapist. So let's say maybe you have a bad relationship with your mother, you're talking about your mom in therapy, and then you all of a sudden are becoming more hostile to the therapist. Maybe you're more gruff, you're shorter in your responses, things like that. In this case, the therapist might interpret it as, oh, this individual's not really mad at me. They're really upset with their mom still, and they're transferring that experience to me. Resistance, it's not always easy to say whatever's on your mind. Some people find that difficult. And that too is a sign of conflict, is a sign of tension, according to Freud. This is sort of the historical look. This type of therapy used to be the gold standard. Nowadays, it has become fairly niche, meaning not a lot of people are trained in psychodynamic therapy, psychoanalytic therapy. Nowadays, if somebody is trained this way, there's a much bigger emphasis on the conscious mind, relationships, and focusing on the self. Basically, all the stuff that Freud and his followers denied for years, now it's kind of come full circle. Humanistic therapy is sort of the antithesis. The follow-up to Freudian therapy focuses on the conscious thoughts, what we're experiencing in the here and now. The belief is built on every individual has a capacity to heal, to grow, to improve, and also to be fulfilled in life, to reach our potential, to meet our unique potential. So the goal of this kind of therapy is to generate more self-understanding. Everything when we talk about with humanistic psychology is self-centered. Focus on the self. So better understanding of self, achieving personal growth. Those are the kind of the big things we associate with humanistic psychology. And the name you should associate with that approach is Carl Rogers, who talked about client-centered therapy or person-centered therapy, depending on the textbook. But the idea is that the client is at the center of their healing and their improvement and ending their suffering. So the therapist's job is to through questioning, through active listening, sort of help the client explore self aspects of self in a non-directive way, by being warm, being supportive, being active listening, being reflective. So when, maybe the client tells you something, and then as a therapist, you don't just say it back verbatim. You don't say it back word for word, like, oh, you just said this. No, you say, oh, I think if I'm understanding you correctly, it sounds like you're saying this and it made you feel this way. Am I correct? And basically what you're doing there is serving as a mirror, so you can validate what, give that person the other sense that they're validated and they've been heard. Also, the therapist is they're in terms of optimal outcome, it's to treat their clients with unconditional positive regard, like understanding that even though, everybody makes mistakes. All humans make mistakes. So people coming to therapy are probably, beating themselves up already for mistakes they've made or think they've made. So as a therapist, you are there to provide support, even when they are at their lowest, even when they've made mistakes. It's not, your desire to treat them is not conditional. It's also to develop, show empathy and be genuine with them. Don't sugarcoat things, don't lie. Oh, it's all going to be better. Oh, it's not so bad, or being very genuine, keeping it 100, as they might say. Behavior therapy is just exactly like it sounds. We want to modify behaviors. The goal is to change overt behaviors. Basically, we want to reduce or eliminate maladaptive behaviors and replace them with appropriate behaviors. And this is using principles of classical and operant conditioning, which we talked about in a previous chapter. There are social cognitive approaches, kind of thinking about some of that Bandura, observational learning we've also talked about. There are classical conditioning techniques, systematic desensitization. If you want to treat phobias, for example, you can systematically desensitize an individual to the stimulus they're afraid of. So for example, the picture here, if you're afraid of snakes, you might start off by being exposed to a picture of a snake. And then eventually you're in a room with a snake in a crate. And eventually you build up to where you can hold a snake. The idea is being exposed in a systematic way, you overcome that fear, that phobia. You have to basically develop sort of a hierarchy. Okay, here I'm a little afraid, up here I'm very afraid, and we're going to work our way up, and also teach, techniques for kind of, relaxing during those moments as well. Aversive conditioning, this is also, you can pair an undesirable behavior with an aversive stimuli. So for example, drinking alcohol, there is a medication called antabuse that if you take by itself, it is benign, it does nothing. But as soon as you pair it with alcohol, it makes the person who's consumed antabuse and alcohol very sick, very nauseous. And the idea is, okay, if I associate drinking alcohol with that feeling of nausea, feeling sick, wanting to, throw up perhaps, then I will no longer want to drink alcohol. And that can work as long as the individual is willing to take, the drug, for example. If you stop taking the drug, it's voluntary. So here's an example of systematic desensitization. You look at, okay, if you have test anxiety, some things that you could do kind of systematically, replacing your fear with relaxation and visualization all the way from a month prior to the exam up until when you're actually writing the exam. Maybe you're practicing some of these ideas, maybe getting exposure to what you can. Maybe you have some practice exams, or maybe you can ask your teacher for some practice questions or things like that. And this way you can kind of, go from maybe step one, you're pretty tense, you're pretty nervous, and maybe it's debilitating, to taking exams to all the way to step 14. Now you're, taking exams fairly comfortably. Of course, if you're, working with the, with your therapist on this. So, this is the example of the aversive conditioning I talked about. You have a drug, antabuse, it evokes a nauseating response. And the idea is this creates an unlearned reflex, bias. We create that association with alcohol, that pairing those two together, we acquire or learn alcohol. We learn to associate that alcohol induces that nausea, that response. So alcohol becomes a conditioned stimulus in this case, and nausea is a conditioned response. So behavior therapies also can utilize elements of operant conditioning, unlearning maladaptive behaviors such as, obsessive compulsive disorder, altering consequences, reinforcing some behaviors. In school, also you see this a lot with what's called applied behavior analysis, modifying behaviors, using positive reinforcement of adaptive behaviors, ignoring to extinguish maladaptive behaviors like inappropriate behaviors at school. Doesn't necessarily depend on gaining insight necessarily. It's really just, okay, we have this problem, we need to fix it. We're not necessarily concerned with the thoughts that are happening about it. We just want to get the problem to stop. So behavior therapy is used to modify behaviors. Cognitive therapy is used to modify thinking. Anytime we see that word cognitive, we want to, think of thinking. So thoughts, according to this approach, thoughts, the way we think is the source of our psychological problems. So we need to alter how we think, which controls how we feel. And this is very different from Freudian therapy. Instead of focusing on what's not here and now, the unconscious, we want to focus on things that are here and now, like problematic thinking. So there is a structured analysis and guidance to it, which is very different than Rogers. So it's kind of the antithesis to two of those approaches we've talked about. Really being, upfront, like, hey, you are thinking this way and it leads you to act this way. We need to stop that. The goal of this kind of therapy is to restructure thoughts, to change the way we interpret events, for example. So one of those things is to identify and challenge automatic thoughts, recognize logical errors in our thinking. So some of those might be ignoring evidence of positives, overgeneralizing negatives, magnifying the importance of events, like absolutist thinking, kind of black and white, this or that, all or nothing. We want to change that kind of thinking. And this is getting into really, if we take behavior therapy, we take cognitive therapy, and we mold them together into a sweet, awesome Voltron of therapy, we get cognitive behavior therapy. It's the idea that cognition and behavior are sort of intertwined, and to treat one, you need to also treat the other. And a lot of what we know about this comes from Bandura, self-efficacy. The idea is we can reduce self-defeating thoughts and also incorporate elements of behavior therapy and give individuals self-instructional methods to kind of do these things on their own, like as homework, learn the skills that, hey, you're not going to be in therapy forever. So maybe you need to learn some skills that you can use outside of therapy. And nowadays, cognitive behavioral therapy is the gold standard of therapy. It's the most common form of therapy used today. So this is just a quick rundown of all these different therapies, in terms of the problem, the emphasis, and then the techniques that are used. So take a look at that. You can pause here and maybe take a screenshot if you want. It's also in your text. So there's that for you. Now we're going to look at some updates in terms of therapy. Traditionally, you had to go to a therapist's office in order to receive psychotherapy. Now that is changing. We can now do therapy on our phones. You can do them on your computers. You have e-therapy. You have mobile internet apps. There is still a lot of research being done about how effective these can be. Should they be used as their own form of therapy, or should they be used to complement other existing interventions? The thing about these, though, is they do offer a cheaper alternative to psychotherapy, which could be pretty expensive. So, and just things, if you're considering these things, just things you need to ask or look into, are the therapist qualifications provided? What kind of patients are seen? And because there might be a risk that they might not be serving people who have thoughts of suicide. So these are questions you might want to ask. Is your confidentiality guaranteed? Is there evidence that it's proven effective? I don't have the research in front of me, but I've heard, I've been hearing kind of around the grapevine that services like BetterHealth and some of those mental health services, I need to look more into myself, but maybe have, leave something to be desired. So I just think it's important to ask questions up front. Don't just, assume, oh, I saw this on TV or, whatever, and it must be good. It may not be true. So it does make therapy available to people who probably, maybe didn't have access. So that is a good thing. Ideally integrated, ideally therapy, ideally for the best approach is using combinations. It's not just saying, oh, I'm a psychodynamic therapist or I'm a cognitive behavioral therapist. It's really figuring out what fits and works for the client. And so again, it's that evidence-based practice. So really embracing this integrative therapy where you might end up using a combination of therapeutic techniques because that is the best benefit to your client. Think about it. Each form of therapy is like a tool. And the more tools you have in your toolbox, the more prepared you are to treat a certain disorder. So therapy integrations might be one of the most common ones is just simply combining psychotherapy and drug therapy, dialectical behavioral therapy, again, kind of getting into some of that ABA. And then, these are consistent with the biopsychosocial model of abnormal behavior, meaning we treat it holistically. It's not just a biological phenomenon. It's not just a psychological phenomenon. It's not just a cultural, it's all three. So now we're going to switch gears for the last few slides and talk about biomedical therapies. These are used to reduce and eliminate symptoms of mental illness by changing body function. So maybe that's at the level of the neurotransmitter, or that can be something even more broadly as like psychotherapy. So we have drug therapy, we have electroconvulsive therapy, and psychosurgery are the three big buckets we're going to put things in for biological. So drug therapy, for example, treatment of anxiety and anxiety disorders, obsessive compulsive, PTSD, you might use anti-anxiety medications, benzodiazepines, buspirone. These are very common. They're very effective at treating anxiety, but they're also can be addictive. And also you can run the risk of, if you mix them with alcohol, they can be dangerous, in fact, even lethal. Antidepressant drugs, several classifications, tricyclics, tetracyclics, MAO inhibitors, selective serotonin reuptake inhibitors, or SSRIs. That's a very common one. Fexor, which is a serotonin norepinephrine reuptake inhibitor. These are pretty commonly used for treating depression. And also you see these drugs like SSRIs are commonly diagnosed or prescribed for individuals with anxiety. Bipolar disorder, to treat the manic symptoms, it's going to be a drug that has some element of lithium or some amount of lithium in it, which is a simple salt, for some reason appears to treat the symptoms of mania. SSRIs mentioned earlier, these are selective serotonin reuptake inhibitors, meaning these prevent the reuptake process of serotonin. The idea is you have dopamine, you have an excess amount of serotonin, or you have not enough serotonin, so instead of reabsorbing any back in the reuptake process, your synapses, your neurons are able to keep that and maintain a healthy amount of serotonin. Antipsychotic drugs, literally life-saving drugs, neuroleptics, these are drugs intended to reduce the positive symptoms of schizophrenia. I think the newer drugs do positive and negative symptoms, but those first class of drugs really only worked for the positive symptoms. And these are very effective drugs, meaning they can reduce psychosis, but they do have side effects. One of those is tardive dyskinesia, painful muscle spasms, sometimes in the face, sometimes in other muscle groups in the body, but very uncomfortable experience. Atypical antipsychotics are a newer classification, and these actually will treat, again, those positive and negative symptoms both. Electroconvulsive therapy is otherwise known as shock therapy. Nowadays, it involves a small electric current produced directly to the brain to elicit a brief seizure. It is done in very low doses, and it's only used for treating severe depression if individuals are not responding to other treatments. So if somebody is suicidal and they're not responding to medication, they're not responding to psychotherapy or some combination, this could be a last, kind of resort treatment. This procedure has undergone a lot of changes. It used to be much more barbaric, much more dangerous. The side effects were much more pronounced. I mean, it still can affect your brain. People complain of like memory loss and inability to think as clearly after these procedures, but it does appear to be pretty effective for treating depression. Transcranial magnetic stimulation, pretty similar, but it's, using magnets on the brain rather than electric current. And it also appears to be pretty effective for depression, but not as harmful in terms of side effects. There's also psychotherapy or psychosurgery, the prefrontal lobotomy, which is no longer in use. Simply meant severing the prefrontal lobe from the rest of the brain. You have deep brain stimulation, another approach. So those are, those psychosurgeries are, again, if other forms are not working, then this might be our last resort. So we've looked at biomedical, we've looked at psychotherapy. Now we'll look at sociocultural approaches to mental health treatment. And this is coming from the understanding that individuals, yes, they're an individual, but they're part of a system. They have relationships, they're interwoven into society and various societal and cultural factors that need to be taken into account. So approaches in this case, might involve group therapy, family therapy, self-help groups, community mental health efforts. But again, the emphasis on improvement is going to happen together, not in isolation. So in group therapy, you might have individuals who share a disorder, perhaps. You might have a professional who facilitates that kind of group therapy setting. It is typically cheaper. You have that support from other group members who maybe are experiencing the same things. You can develop social skills by working in a group around other people, and also receive information, to learn more about the disorder. Family and couple therapy is looking at specifically the social unit of the family and treating symptoms at the level of relationships. Like, hey, your mental health isn't just affecting you as an individual; it's also affecting your partner, your children, your immediate family, and really trying to focus on repairing that family dynamic, validating, reframing issues, providing structural change to the dynamics of the family if need be, detriangulation, kind of de-escalating things, as needed. So, it's a different kind of, there's a lot of overlap in some of these types of therapies, but some of them are, kind of unique to their own setting. You have self-help support groups, maybe Alcoholics Anonymous, Gamblers Anonymous, things like that. You have an audience, you have social support, you have role modeling, maybe seeing people overcome things like addiction. You're able to share strategies in terms of how you are dealing with addiction or dealing with the problem, and get to hear from other people how they're dealing with it. So that's good. There is a downside though, that those group settings can be very helpful, but you have to be careful. And, people are carrying a lot of emotional baggage with them. And sometimes that negative emotions can kind of spread. And I don't want to say contaminate, like it's a virus or something. It's not like quite that severe, but it can really kind of flip the overall kind of feel of the therapy session pretty quickly. Community mental health, deinstitutionalization. We see a lot of people who maybe once used to receive treatment in state mental health facilities. Now they don't have access to those anymore for all kinds of reasons, and in fact may be homeless now. The idea is preventing this before it happens, empowering individuals to take care of their mental health and providing resources before maybe it gets to a problem like being without a home. Different perspectives will also have, it's also important to take into consideration culture when it comes to administering therapy. People who come from individualistic and collectivist cultures will have maybe different thoughts or approaches on how treatment might look. You want to make sure that the therapist does have cross-cultural competency. Does it need to be a match between the therapist in terms of ethnicity, in terms of gender? There's probably evidence to suggest one way or the other. It probably is easier for people to open up to people who are like them. If you come, let's say if you're an African-American female, maybe it would be easier for you to open up to an African-American female as a therapist. But I mean, it's, that's definitely not to say that the reverse could be true. You could open up to a Hispanic male therapist or whatever. I mean, it kind of depends. I think in terms of gender, there is newer techniques being developed around feminist ideas to be more responsive of clients who identify as female. I think there might be some similar symptoms and problems between genders, but I think how we approach it might need a little more nuance. So I'm starting to see more of that. So that's going to be it for chapter 13. Kind of a shorter chapter, but it's a good follow-up to chapter 12. Now you know how those disorders are treated. Chapter 14, our last chapter, we're going to look at how mental health affects physical health in terms of stress, how we process stress. So stick around for that. Let me know if you have any questions. Otherwise, I'll see you for chapter 14. Peace.